This conference will now be recorded.
So the maternal ABO and D blood group alloantibody status should be ascertained at booking as well as um, at 28 weeks of gestation. So the RCOG recommends routine screening of all the women, all the pregnant women for blood group as well as alloantibody status at booking and 28 weeks. This is really important. This can come in the exams as well. Pregnancies with high chances of HDFN include those with previous history of fetus or the newborn affected with hemolytic disease and who have a critical level of alloantibody. So those who have detected at booking or at 28 weeks with a high risk alloantibody, and those who have got a previous history of newborn or the baby being affected with hemolytic disease, they're at higher risk of having HDF then in the present pregnancy as well. The advent of cell-free fetal DNA, that is CFF DNA, testing from the maternal blood allows non-invasive identification of the fetal RBC antigens, including DCEK. So this is called non-invasive fetal genotyping. So this is available for certain antibodies, that is DCEK. So the sensitivity and specificity of this cell-free fetal DNA RHD genotyping is almost 100%. So it can be considered as a diagnostic test when used in this context. So as this is a non-invasive test, um, so the chance of other invasive side effects from other invasive testing are less. So this is becoming used widely nowadays. Rhesus D, C, E are detectable from 16 weeks, whereas K from 20 weeks. So we can do this cell-free fetal DNA testing in case of DCE from 16 weeks and in case of K from 20 weeks. So alloimmunized women require blood tests. So from when the antibody is detected, they require blood test every 4 weeks up to 28 weeks, and then every 2 weeks thereafter till delivery. So this is an important point, the how to monitor the women who have alloimmunized antibody already detected. So already detected antibody, then the women needs to be screened every 4 weeks up till 28 and then every fortnightly thereafter. So absolute levels of alloantibody or a rapid rising level, so absolute higher levels of alloantibody or a rapid rising titers, that is doubling over every 14 days, are important, as these can cause severe fetal anemia. So the routine use of RHD immunoglobulin has reduced the rate of red cell alloimmunization, with developed countries following established protocols for immunoprophylaxis with anti-D IgG. So all the developed countries and even in the developing countries, the routine use of RHD immunoglobulin has decreased the incidence of this red cell alloimmunization. So apart from the routine dose of the anti-D immunoglobulin, an additional dose is required whenever there is a sensitizing event within the next 72 hours. If it is better, it is given as soon as possible. If it is not possible immediately within 72 hours, it should be given. So whenever there is a sensitizing event, there will be possible fetal-maternal hemorrhage. So additional dose apart from these prophylaxis and doses needs to be administered. Adequate dose, that is 500 international units of anti-D, is sufficient to cover 4 ml of fetal-maternal blood hemorrhage. So Kleihor-Betke test needs to be done to see if there is any after 20 weeks. We have to see if there is any if the dose is enough or not. If there is any additional hemorrhage, then we need to cover that also. So we need to do a Kleihor-Betke test to assess the amount of fetal-maternal hemorrhage and then give the dosing accordingly, further dosing accordingly. So this has been summed up in the form of a chart. This is taken from the red cell antibody TOG. So the same, it says the same thing as it is mentioned here, because all the women will have a, a booking test as well as a repeated test at around 28 weeks for both the blood grouping as well as the antibody screening. So if there are any clinically significant antibodies, they'll be monitored, especially DCK. These will be monitored every monthly up till 28 weeks and then every fortnightly, that is test every 2 weekly until delivery. So all other clinically significant antibodies, um, we either need to do paternal or fetal genotyping to see if the baby is at high risk. So, and monitor accordingly. If there is nothing like that, then repeat the antibody screen at around 28 weeks. And at birth, the cord blood should be subjected to DAT, that is a direct agglutinin test, hemoglobin, and bilirubin to assess the risk for the baby. If there are no clinically significant antibodies, also we need to repeat the testing at 28 weeks again to see whether there's any positive status, if it is negative at booking. If there is no antibody and no further action, if there is a clinically significant antibody, she needs to followed up with regular tests every fortnightly. So again, this is from that green top guideline. So we need to do uh, maternal as well as the fetal testing. And for fetal, it can be cell-free fetal DNA, that is FFDNA. And if it is positive, then the fetus needs to be closely monitored. So these important numbers are these numbers are important. In case of anti-D, 4 to 15 is a moderate risk of HDFN, and more than 15 is a severe risk of HDFN. So above 4 units per international units per ml, the woman needs to be referred to the fetal medicine unit for further monitoring. In case of anti-C antibodies, if it is above 7.5, the woman needs to be monitored and she needs to be referred to the fetal medicine unit. And these are what are the clinically, there are said like 50 types of red cell antibodies. These are some of them. That is the most common being the rhesus D. Then comes C and E, K, and they are Duffy, MNS. Apart from the rhesus system, there is Duffy, MNS, KID, and KEL systems. Among these, D, C, E, K can cause severe fetus, frequently severe HDFN in fetus as well as the neonate. In other systems, it can be milder, so only usually it causes only in the neonate and does not usually affect the fetus. And also it is infrequently severe, not as severe as these antigens like C, D, and K. And regarding the sensitizing events for Rh negative women in pregnancy, so we know that apart from the routine prophylaxis, we need to give additional dose of anti-D immunoglobulin at every sensitizing event. And these can be ectopic or early miscarriage complicated by pain or excessive bleeding. Um, Whereas a spontaneous miscarriage does not warrant for any anti-D immunoglobulin. So uterine instrumentation or evacuation, like with miscarriage or any molar pregnancy and termination of pregnancy, needs anti-D. And also any pregnancy loss after 12 weeks, or intrauterine death or stillbirth, and any invasive tests like amniocentesis, CVS, and chordocentesis. Any fetal therapies, invasive fetal therapies like transfusions, surgery, shunts, laser, and fetal reduction, all these also need anti-D. And also external cephalic version, abdominal trauma, it could be blunt or sharp trauma, anything, it needs anti-D. And also delivery, regardless of the mode of the delivery, it could be vaginal or cesarean. And also intraoperative cell salvage needs additional anti-D, as these are potentially sensitizing events. So coming to the infections, human parvovirus infection is the most common infection causing red cell alloimmunization. This is fetal anemia. Sorry, this is non-immune cause, so it causes fetal anemia through red cell destruction, which is also called a slap cheek syndrome, and is the most common cause for viral related fetal anemia in the UK. So more than half of the pregnant women will be immune because of the infection before the pregnancy. But in those without such immunity, infection in the first half of the pregnancy can cause fetal anemia, high drops, secondary to the viral destruction of fetal erythroid progenitor cells. So it also causes fetal RBC destruction and fetal anemia. The risk of fetal loss is estimated to be 13% with parvo-19 if it occurs before 20 weeks, and 0.5% with the infection occurring later in pregnancy. After 24 weeks, the chances of fetal anemia and high drops are quite less, just like 0.5%. However, before 20 weeks, it is around 13%. And cytomegalovirus is another important cause of maternal infection that can cause fetal anemia. So avidity is an important property in testing, with the strength of the IgG and antigen complex gradually increasing with time after primary infection. So this is really important regarding the avidity. If there is a low avidity, that means it is a recent infection. That is in the last 3 months, the infection. If it is a high avidity, then it means it is a remote infection. So this is an important point. Low avidity is suggestive of recent infection. So CMV, when we have a um, suspicion, we need to test for the avidity to see if it is a IgG is positive. If it is IgG is positive, we should not leave it. We always test for avidity to see if it is a recent infection or a remote infection. So rare and infective causes of fetal anemia include toxoplasmosis, syphilis, malaria, rubella, and herpes. Okay. And next comes the disorders of erythropoiesis. So fetal anemia can result from problems at any stage of the cell production in the bone marrow. It can be secondary to inherited anemias, metabolic syndromes, or bone marrow failure. Aplastic anemia can result from toxicity of the drugs or radiation or underlying genetic problems. So fetal anemias can occur because of the inherited anemias or other syndromes, or it can be from toxicity of the drugs, radiation, or any genetic problem also. So in this, alpha thalassemia is predominantly in couples with Mediterranean and Asian origin, is the most common type of inherited anemia in the fetuses. So genetic disorders of red cell production like congenital erythropoietic porphyria, Fanconi anemia, diamond blackfan anemia are the also can cause fetal anemia. In alpha thalassemia major, the complete lack of normal hemoglobin leads to so-called Bart hydrops. So it complete lack of fetal hemoglobin because all the 4 genes are affected, and all the globin mm, there is no globin manufacture at all, so the hemoglobin is completely abnormal. So it's called Bart's hydrops fetalis, which can be mirrored by maternal preeclampsia and is associated with antepartum hemorrhage. So in this, because of the Bart's hydrops, it can mimic maternal preeclampsia, and there's a high chance of antepartum hemorrhage. A markedly thickened placenta is also a classic sonographic sign in case of this Bart's hydrops. A transient abnormal myelopoiesis has an association with, there's also condition in trisomy 21 in Down syndrome fetuses. There could be transient abnormal myelopoiesis. And also G6PD deficiency is an X-linked hemolytic anemia, most common in the African ancestry groups. And G6PD, we know that the red cells are less tolerant to oxidative stress. So whenever there's an oxidative stress in case of infection or maternal fava bean ingestion or any drug toxicity, there could be red cell destruction. There is also other conditions like pyruvate kinase deficiency, glucose phosphate isomerase deficiency. These also can cause fetal anemia. And coming to the tumors, it could be placental or fetal tumors. So any tumor of the fetus or the placenta that sequesters red blood cells can cause fetal anemia. So the most common the fetal tumor being sacrococcygeal teratoma, which is the most commonest fetal tumor, in which red cells can be consumed or damaged as they pass through, and they can be bleeding within the tumor, leading to fetal anemia. And a giant placental chorioangioma can be seen on the ultrasound and color Doppler as a mass protruding into the amniotic cavity from the placenta with high vascularity, and may cause hyperdynamic circulation and also association with polyhydramnios. So there could be other tumors like hemangiomata, for example, fetal hemangiomatas and fetal AV malformations. All these can cause fetal anemias, though these are rare conditions. Next, fetal-maternal hemorrhage, also the transplacental hemorrhage. So any antepartum hemorrhage can cause loss of fetal red blood cells into the maternal circulation. So women present without overt clinical signs of bleeding and reduced fetal movements may be the only clue. Sometimes there could be uh, no clinical signs, and reduced fetal movements may be the only clue. So fetal-maternal hemorrhage can be detected by Claude-Bethke test or flow cytometry. A sudden large bleed, as in placental abruption or ruptured vasa previa, can cause fetal hypotension, acidemia, and eventually death. Coming to vasa previa, a diagnosis of vasa previa may be made by the following: painless vaginal bleeding coinciding with the membrane rupture and fetal compromise. So if discovered in an asymptomatic women, the RCOG guidelines support the delivery by cesarean section at 34 to 36 weeks, as further waiting can cause severe mm, serious complications and sometimes fetal death can occur. So the pregnancy has to be terminated at 34 to 36 weeks after giving steroids for fetal lung maturity. And complications of monochorionicity in multiple pregnancies, like fetal anemia, can be a consequence of vascular anastomosis connecting the fetal circulations in multiple pregnancies with a shared placenta, that is monochorionic pregnancies. So specific complications of monochorionicity are subacute or chronic anemia associated with twin anemia, polycythemia sequence, that is TAPS, and acute anemia in the surviving fetus following a co-twin demise. There could be anemia in the co-twin when there is a single fetal demise, and also that in the TAPS also we can see the anemia in the donor twin. TAPS is defined by a significant discordance in hemoglobin levels between the twins without substantial difference in the amniotic fluid volume. Uh, Typically, there could be very less difference in the amniotic fluid volume in TAPS, only difference in the hemoglobin levels is seen. Prenatal prediction relies on ultrasound Doppler imaging of the middle cerebral artery peak systolic velocity. So MCA-PSV only is the way to monitoring these fetuses with TAPS. TAPS arises from a chronic transfusion of blood from donor to recipient fetus via um, a minuscule, a small AV anastomosis, that is less than 1 mm, AV arteriovenous anastomosis. It spontaneously affects 5% of all monochorionic diamniotic pregnancies. The TAPS incidence is around 5%. After fetoscopic laser ablation for fetal transfusion, TAPS has been reported in 60% of the cases. So we do fetoscopic laser ablation for twin transfusion syndrome. So fetal transfusion syndrome is a complication of the laser ablation. So in that cases also TAPS can occur in 16% of cases. It is associated with incomplete ablation of the placental anastomosis, although Solomon technique can reduce the incidence by 3%. So Solomon technique is the technique for fetal laser ablation which is commonly used. So with that technique, the complication is around 3%. Single intrauterine fetal death complicates around 1 to 2% of the monochorionic twin pregnancies. So single fetal demise also can occur in 1 to 2%. In this event also, the co-twin can have fetal anemia. Following this event, an acute transfusion from the surviving co-twin to the demised twin can occur, leading to anemia, with the surviving co-twin being at significant risk of subsequent brain injury and death. So there should be a monitoring for that baby, for the existing fetus. So what are the principles of management of fetal anemia? So identifying an anemic fetus is of prime importance because we can detect the at high risk fetuses at early stage, then we can avoid complications in them. Pregnancies at high risk of fetal anemia can be identified antenatally from all these needs to be considered to identify a high risk fetus for fetal anemia. That is the booking history, routine screening to detect the antibodies at around booking, that is around 12 weeks and around 28 weeks of gestation. Ultrasound evidence of hydrops fetalis are a high risk fetal condition. All these to be kept in mind in identifying the high risk fetus. So Paris women should be asked at booking regarding their prior transfusion history in the previous pregnancies and previous fetal and neonatal transfusions, any history of severe neonatal jaundice. All these point towards having a repeat of such condition in the present pregnancy. So this history is mandatory. High risk cases should then be evaluated early by fetal medicine specialist. Sometimes if it is a very high risk case, we need straight away referral to the fetal medicine specialist. Fetal blood sampling is the gold standard for diagnosis of fetal anemia, but carries a procedure-related risk of miscarriage or preterm birth up to 2%. So direct fetal blood sampling, though it is a gold standard, it has got some risk because it is an invasive procedure. Doppler ultrasound assessment of fetal MCA-PSV is used to screen fetal anemia. So MCA-PSV Doppler, middle cerebral artery peak systolic velocity, is used to screen for anemia. The action line and consideration of fetal blood sampling is required at 1.5 moms for the gestational age. If anything more than 1.5 multiples of median above the normal, then we need to consider fetal blood sampling. So what happens in case of in a severe anemic fetus? There is extramedullary hematopoiesis. Apart from the bone marrow, there could be extramedullary hematopoiesis, which can lead to hepatosplenomegaly, liver congestion, and in turn leads to impaired synthetic function, hypoproteinemia, and there could be extracellular fluid accumulation. That is how the hydrops occurs. So effusions, ascites, edema, polyhydramnios can be detected by ultrasound in hydrops fetalis, defined as abnormal fetal fluid collection in two or more compartments. That is fetal hydrops definition. When non-immune hydrops is detected on ultrasound, maternal well-being should be assessed, and like with assessment of the blood pressure, dipstick urine analysis to rule out maternal preeclampsia like mirror syndrome. So there's also a syndrome called mirror syndrome or the Ballantyne syndrome, also called the triple edema, where there's a edema of the fetus, the placenta, and the mother, and it can also mimic preeclampsia. So we need to check her blood pressure and dipstick urine analysis to rule out preeclampsia in such women. MRI estimation of fetal hematocrit is also being proposed as a specific imaging technique to identify fetal anemia. However, this is more expensive and it is not cost effective, so it can't be routinely used. Anemic fetus may present with unusual fetal heart pattern on cardiotocography. As we know, the anemia has a sinusoidal trace of pattern. So a sinusoidal trace may be the first objective sign of anemia or sudden feto-maternal hemorrhage and should trigger urgent senior review for consideration of imminent delivery. So whenever we see a sinusoidal trace, so it is it's an emergency situation. So it can denote either severe anemia or severe sudden feto-maternal hemorrhage, and imminent delivery is recommended. Intrauterine transfusion. So the first intrauterine transfusion occurred in 1963 and is now performed as an ultrasound guided percutaneous needle procedure. So for the intrauterine transfusion, the vascular access is commonly via the umbilical vein, either at the placental cord root or at the intrahepatic vein, at the region of the intrahepatic vein. The later with the lower complications. So sometimes umbilical cord loops, free loops may also be used for this venous access in case for intrauterine transfusion. In obese women or at earlier gestations, that is less than 20 weeks, when intravascular transfusion is technically challenging, intracardiac transfusion may be performed. So in early gestations, when it is not possible to identify the cord loops and all, especially in the obese women, intracardiac may also be considered. In modern fetal medicine, intraperitoneal fetal transfusion is used to manage fetal anemia. We can also intraperitoneal route also can be used only in a non-hydropic baby. In a hydrops baby, this cannot be used. Prior to 20 weeks of gestation, often used in combination with maternal IV immunoglobulin therapy in severely alloimmunized women. In severely alloimmunized women, there could be early severe fetal anemia prior to even 20 weeks. So then we can use intraperitoneal fetal transfusion. And regarding the medical treatments, IV immunoglobulins at high doses may block the transport of alloantibodies across the placenta by competitive inhibition. So IVIG can reduce maternal alloantibody and delay clinically significant anemia until intrauterine transfusion is required. So in case of severe alloimmunization, IV immunoglobulins have a role to play. And maternal plasma exchange can clear alloantibodies from the maternal circulation. So it can be beneficial when a previous pregnancy has been severely affected by fetal anemia, or if large quantities of Rh positive red blood cells need to be cleared from a Rh negative patient acutely. So potential adverse effects with maternal exchange being infection and hematoma formation and altered maternal and fetal hemodynamics, as well as loss of systemically important proteins. Maternal plasma exchange can cause these complications. So these needs to be kept in mind. Immunomodulatory therapies may prevent alloimmunization in high-risk women prior to RBC antigen exposure, but current evidence is limited. So the The latest treatments available would be IV immunoglobulins in case of high and also maternal plasma exchange and immunomodulatory therapies till the limited evidence is there for the use. Outcomes of fetal anemia. So what are the different outcomes? Red cell alloimmunization causes around 50,000 stillbirths per year worldwide, and countries with comprehensive antenatal care have reduced prevalence of HDFN to 2.5 per 1 lakh live births. And for babies with antenatally diagnosed anemia, deferred cord clamping at the time of delivery has been shown to reduce the need for neonatal exchange or top-up transfusion. So cord blood of the at-risk babies is screened for HDFN by performing a DAT test, that is direct agglutinin, hemoglobin, and bilirubin after a positive screen to make the diagnosis. These maternal antibodies can remain in the baby's circulation for up to 6 months. So this can cause continuing red cell destruction and lead to chronic unconjugated hyperbilirubinemia, and maybe if left untreated can cause brain injury with kernicterus. Neonatal jaundice is treated with either, if it is mild, with the phototherapy, or if it is severe, with exchange transfusion. And cholestatic jaundice, that is conjugated hyperbilirubinemia, complicates the postnatal course of 13% of HDFN cases. So, and is associated with intrauterine transfusion and RHD alloimmunization. So this is also a cholestatic jaundice also can occur in 13% of the cases. And early neonatal anemia in HDFN within 7 days, it is early neonatal anemia. It is usually determined by the in utero events, and late anemia it could be hyporegenerative or because of the hemolytic etiologies. So top-up transfusions can occur in 4 out of the 5 neonates with HDFN until late postpartum anemia resolves. So the baby might need top-up transfusion apart from the intrauterine and immediate post delivery transfusions. They might need post top-up transfusions until the anemia resolves. Multiply transfused babies are potentially at risk of iron overload. So multiple transfusions can lead to fetal iron overload in the neonates. After TAPS, the do not win is increased risk of neurodevelopmental impairment. So these are all the different outcomes of the fetal anemia that can affect the fetuses. So the do not win is at increased risk of neurodevelopmental impairment in TAPS, and the incidence of cognitive delay and deafness is increased. They might need a long-term follow-up. And regarding Miller syndrome, I have told that it is a triple edema. It's a rare condition. So all these points are again summed up in the chart. So I just can go through quickly. So in case of red cell alloimmunization, we need to ask regarding the history of previous baby requiring transfusion or history of previous hemolytic disease in the newborn. That needs immediate attention. So the testing would be maternal blood group and antibody status at booking as well as 28 weeks. It's a routine thing and it is recommended by RCOG for all the pregnant women. So in case of a positive allo antibody, then a fetal and paternal genotyping also needs to be done and refer to the fetal medicine specialist will be done, especially when there's a history of prior HDFN, ultrasound evidence of fetal anemia or high drops, and rapid rising in the antibodies, or if the anti-D is more than 4 international units, then if the anti-C is more than 7.5, and anti-K as soon as it is detected, no need for a titer. Any other allo antibody apart from these at titers more than or equal to 32, they need referral to the fetal medicine unit for further monitoring immediately. So if there's a maternal transfusion is likely, they need regular cross-match samples. In mothers at high risk of transfusion in case of like placenta previa cases or any hemoglobinopathies, sickle cell anemia, there's a high risk of transfusion for the mother. In such cases, in the women with the antibodies who are at high risk, they need regular cross-match samples to be sent to the transfusion laboratory, because it is recommended that every week a sample needs to be sent and to keep the blood ready. Next comes the fetal infection. So we need to ask regarding the febrile illness, any rash, history of exposure to the contacts, if it is a significant exposure, if it is a face-to-face or 15 minutes within the same room is a significant exposure. There's no routine screening for these infections. However, we need to check the booking sera for IgG to see the seroconversion. To see the immunity, we need to see the booking sera. And current blood sample, so whenever there's a symptomatic woman or asymptomatic woman with the contact with the viral mm, with the virus, so a current blood sample is also required. And again, retesting of this after 1 month, if the initial test does not show any IgG or IgM, so we need to repeat the test after 1 month. And consider amniocensus or fetal blood sample to detect viral DNA. To see fetal viral DNA infection, we need to do an invasive procedure. And serial ultrasound scanning from 4 weeks after the symptom onset. As soon as the symptoms are over, we need to after the symptom onset, every 4 weeks, we need to keep scanning the baby for any sequelae. Parvovirus B19, IgM in the maternal body. So in case of parvovirus, IgM is present in the maternal blood from day 1 onwards. So that is from the day of the rash, we can see the IgM. So if there is no IgM, that means there is no infection in the last 4 weeks. So we need to save the test and see the blood for viral load, and also repeat the sample for change in the IgM status. So immediately we may not be able to sometimes check for the infection. So we need to repeat the sample and see for IgM reactivity, and also scan for the fetus for about 4 to 10 weeks following the maternal infection. So after maternal infection after 24 weeks, usually harmless. So as we said that it is the risk is like less than 0.5% after 24 weeks. In case of CMV, as already discussed, IgGM and IgG are positive. IgG with low avidity, that means the recent infection that is within the last 3 months. If avidity is high, then it is a remote infection that is more than 3 months. In such cases, a termination of pregnancy is usually considered because it has got dangerous sequelae for the baby. So we need termination for that cases. So in case of genetic and metabolic conditions causing fetal anemia, we need to go for the family origin questionnaire, see hemoglobin electrophoresis, parental DNA, and in case of pyruvate kinase deficiency and G6PD deficiency, we need red cell enzyme assays and invasive testing for genetic diagnosis, for prenatal diagnosis. These, if we are suspecting any genetic and metabolic conditions causing fetal anemia. So regarding vascular tumors, regular Doppler to see to check for fetal anemia. We may require MRI in case of any tumors, either fetal or placental, and laser coagulation or radiofrequency ablation of the tumor vessels, and open maternal fetal surgery for resection of sacrococcygeal teratoma is in selected very preterm cases. So this can also be considered. Amniodrainage if there is a severe polyhydramnios, a neonatal team to prepare for microangiopathic hemolytic anemia and thrombocytopenia. When there are vascular tumors, this is the complication. Vasa previa, so a TVS can confirm vasa previa. Most of the times it is an incidental finding. Then the rescan to be done at 32 weeks to confirm it. And then if we still see the fetal vessels at around 32 weeks, then we need to consider delivery at around 34 to 36 weeks after steroid cover. So at every vaginal examination, we need to see the pulsating fetal vessels in the membranes to rule out vasa previa. And as we discussed the complications of monochorionic pregnancies, so we anyhow monitor the monochorionic twins every fortnightly, every once in every 2 weeks from 16 weeks onwards to look for these complications. So whenever there's any height drops or any cardiac dysfunction, unexplained polyhydramnios or abnormal umbilical artery Dopplers or any single fetal demise, these needs to be monitored. They have to be referred to the fetal medicine unit and need to be monitored with Doppler assessment of MCA PSV to detect the STAPS and fetal anemia. So weekly ultrasound surveillance with MCA PSV after fetoscopic laser ablation. Even after laser ablation, every week the fetus needs to be monitored because of the complication, that is fetal transfusion syndrome, and also selective fetal growth restriction can occur, that is like fetal discordance, weight discordance of more than 25%, or the estimated fetal weight is less than 10th centile, that also needs to be monitored. and assess the neuroanatomy of the co-twin survivor with ultrasound and later with MRI after 4 weeks for neurodevelopmental assessment. Fetoscopic laser ablation before 26 weeks and after 26 weeks IUT for anemia. So if it is before 26 weeks, we do fetal laser ablation, or after 26 weeks, we do indirect transfusion for anemia, and also exchange transfusion can be considered. So in conclusion, so fetal anemia is an important condition which all the clinicians should be aware of, and appropriate antenatal screening and identification of pregnancies at risk of fetal anemia will aid in prompt diagnosis. The use of ultrasound and Doppler investigations of MCA, PSV, and referral to the fetal medicine specialist for assessment and therapy has shown to improve the outcomes. Yes, this is the end of that. So, anyone has any queries? This seems to be a difficult, some dry topic kind of thing. This fetal anemia and all that. So, but still, if you have any doubts from this, I can answer. Hello? Hello? Can I end the session? Hello?
Ma'am, that mirror syndrome only, please repeat, ma'am.
Yes, mirror syndrome. It's a very rare form of complication. So it is a triad. This is mirror syndrome. This is also called a Ballantyne syndrome or triple edema. Okay, this is a rare condition in pregnancy. It is defined by the pregnancy of clinical triad of, it has fetal hydrops, placentomegaly, and maternal edema. So edema at all the 3 points, that is called triple edema, at the fetus, the placenta, and the maternal edema. So this can mimic preeclampsia.
Okay.
So this is present in most of the conditions which can cause fetal hydrops, like the immune fetal hydrops and non-immune fetal hydrops can sometimes have mirror syndrome. It mimics fetal, preeclampsia. So we need to differentiate with the monitoring of the BP and obviously
Okay.
dipstick test. Sometimes it can coexist with preeclampsia. So they can be coexistent with preeclampsia. That can sometimes can cause severe complications, and it can be fatal as well in such cases. So we need to look for that in some cases, though it is a rare condition. Okay.
Thank you, ma'am. Thank you, ma'am.
Welcome. Thank you so much. And any other queries? We need a little these charts are common to both this topic as well as the red cell antibodies TOG. So there are certain common points in both the this TOG as well as the green top guideline. So you might need to go through that as well so that you can understand better. Okay. Thank you so much for your patient listening. I'll now close the session. If you have any queries, you can put it in the group also. We can discuss later. Thank you,
ma'am.
Thank you so much.
Thank you.